Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Amir Farouk and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it.
In today's episode, we had the opportunity to sit down with a real legend in transplantation. Dr. Paul Greig is a transplant surgeon who worked for over 30 years at the Toronto General Hospital. We talked to him about what it was like to set up a transplant program and to get his insights into residency and education. Sorry for the audio quality in this episode, but there's some real wisdom to glean here from Dr. Greig. We hope you enjoy. Dr. Greig, I've had the opportunity to talk to many of your trainees and residents who are my friends, and normally we start the podcast
don't believe everything you hear.
But what's clear from talking to them is that, because normally we start the podcast by talking about a clinical topic or reviewing a paper, but it's clear that we have to talk to you about your career first as a transplant surgeon. Can you tell us a little bit about where you grew up, where you did your training, and how you ended up in Toronto? And then the second part of that is why liver transplantation?
Yeah, sure. So I'm a Toronto guy. I was born here in Toronto, did public school education in Toronto. I actually did my undergraduate at the University of Waterloo in math and computers. I was a co-op student at Waterloo. All along the way, I played in some bands, and then when I finished Waterloo, I played in a prog rock band for about a year and a half. And my girlfriend at the time didn't want me to be a computer programmer. She wanted me to be a doctor, so I applied to med school, and I got in. Toronto was the only med school that accepted me, so I went to the University of Toronto, did my medicine here, and was influenced, and then we're going to talk about Langer and stuff like that. But I got attracted to surgery. I did my residency, the Galley program in general surgery here in Toronto. I finished that in 1981, the end of 81. I went to New York. I did 2 years of research fellowship at Columbia Presbyterian Hospital in Manhattan, the best week of my life. Then came back on staff as, I guess what we call it, a liver surgeon at the time in 1984. And so that's my background. Yeah. So I took an interest in liver disease and the diseases and liver surgery from Bernie Langer, without question. He's a heavily influential guy in my life. Basically, he just challenged me more than anybody else had challenged me. I just dug what he did. And I had done some research with him along the way, studying a device called the Levine peritoneal venous shunt that reinfused the acidic fluid through a plastic tube with a one-way valve back into the central vein so people peed it out. Got some publications out of that during my residency. So I was headed towards a life in liver surgery. And quite frankly, I came back on staff at the Toronto General Hospital in 1984, and I expected to do porticable shunts and Whipple operations for a living, because that's what this sort of emerging specialty of liver surgeons were doing. But lo and behold, guess what happened? We started injecting varices with glue and then banding them, and so the shunt went by the wayside. At the same time, Langer had started our fellowship in liver surgery, and Leonard McCowker was one of our first fellows. And Leonard and Bernie had become aware that liver transplantation was starting to become successful down in Pittsburgh. This guy Starzl was transplanting the liver, and they weren't all dying. Some of them were now surviving. And the plan was that Leonard was going to go down to Pittsburgh and learn how to do liver transplants and come back. But while he was a fellow, Bernie said, well, why don't you and Leonard start transplanting some pigs? So we went over to the lab and we started transplanting pigs, and we got the perfusionists to come over and help us do venous bypass. We put pigs to sleep and we transplanted pigs and developed those techniques. And Leonard left in July of '84 to Pittsburgh, and later on that year, I guess it was '85. Later that year, Bernie decided that we were probably ready to start to do liver transplantation. We had done enough in the lab, and that we had a critical mass of liver surgeons, Langer, Taylor, Steve Strasberg, myself. And we did our first transplants in 1985, did a couple more in 1986, and then 1987. He said, well, that's enough for me, Paul. Why don't you take it from here? So there I was, a brand new surgeon on staff with an outstanding opportunity. And that's when we started doing liver transplantation. That's how it happened. Along the way, in 1986, I did go down to Pittsburgh. I went down for a week because Leonard was still there as the fellow, and he sort of made sure that I was well taken care of. And I saw like 6 transplants in 5 days. And I actually scrubbed the Tom Starzl on a bud chiari transplant on the last days up there. So that's actually my formal training in transplantation was 5 days in Pittsburgh. And of course, I had the benefit of the mentorship of Bernie Langer, Bryce Taylor, and Steve Strasberg, and so my forerunners. So that's how I became a transplant surgeon. And the kind of other stuff came on past all as part of all of that.
That's an unbelievable story.
Yeah,
it's really interesting.
Right place at the right time, man.
Yeah, that's fascinating. That's really
cool.
I
consider myself a second-generation hepatobiliary surgeon, but I'm really a first-generation transplanter.
Yeah, exactly. It was interesting. Of course, when you gave the Bill Wall presidential address for the CHPBA, you were referred to in the introduction as a 1.5, and that's exactly where that comes from, eh? 1.2.0. Yeah, it was great. In the Canadian Journal of Surgery, you published a couple of really interesting vignettes or stories, really, about Dr. Langer, that you've touched on, and Tom Starzl, that you've touched on as well. How did those guys, or how did they not impact your sort of outlook on your career outside of the actual technique of liver transplantation and of HPB surgery? And I'm also curious, if you're willing to talk about it, how Bill Wall may or may not have influenced both yourself as well as the Toronto program in general coming out of London.
3 questions. I've already alluded to the fact that actually I was going to be a thoracic surgeon, and then I met Bernie Langer. He just challenged me more than anybody else. And in his way and in his mannerisms and everything, he basically said, let's see you be this good, Paul. He challenged me more than anybody else ever did. I think that's part of the culture of the Toronto General Hospital. There is a lot of pressure to be excellent. And there's pressure to be excellent in every hospital. I understand that, and maybe I'm overstating it because it's the only place I've known. But Bernie did that in spades, and he made what he was doing just more challenging than anything else. And Bernie had a couple of statements: if you don't stand tall enough, you can't see far enough. And he clearly was a visionary sort of guy, transformative to our division of general surgery, our department of surgery. He started the liver transplant program because he thought he could. And he showed me that indeed you need to challenge yourself and take these things on. Just sort of created an atmosphere of excellence that we all emulated, and we all sort of aspired to. So that's probably the influence that he had on me. Of course, the technical aspects. I operate halfway between Bryce Taylor and Bernie Langer. Those are the 2 guys who influenced my surgical decision making and my technical skills. But Bernie just established a standard, a standard of care of excellence that we all aspire to. So that's how he affected me. I would have to say I didn't know Tom Starzl particularly well. I'm not sure he would have known me if we'd seen each other in the hallways. But he showed me, what could be done. As you know, he was such a pioneer and a maverick, and he wouldn't take no for an answer. And although I personally have not been that creative in my surgical career, clearly he was the guy who showed us that if you're determined to make something work, you can make it work. And he made the best of all of his successes. He had lots of failures along the way, but he had enough successes to encourage him along to make this thing work, and that's why we transplant the liver today. So those are the two people who influenced me along the way. As I said, Bryce Taylor was an important factor as well.
Talking about your early career setting up the Toronto Liver Program, I mean, now it's a well-renowned, world-renowned, really, program in liver transplantation. But looking back, what do you think were the critical steps in creating the program, and what were your most challenging struggles in setting that up? And in talking to some of your residents, it seems like there's a lot of synergy between the liver transplant program as well as the lung transplant program. And how do you think that all played out?
So the liver transplant program first, then I'll talk about the relationship with the lung. So the liver transplant, Bernie really developed it in the early days. And I think one of the really smart moves initially was to invite every surgeon who dabbled with the liver in Toronto to come and be part of the liver transplant program if they wanted. Bernie knew that's a big city. He saw that Chicago already had 3 programs, New York had 2, and going to have 2 more programs. And in the Toronto way, at Central University, all that business, he went out of his way to make sure that everyone at the other hospitals at Sunnybrook and the Wellesley Hospital at the time, and St. Mike's and the Western Airways and Mount Sinai, everybody was invited to come and participate. And so what that establishes is a single program, rather than a fractious 2 or 3 programs all fighting against each other for turf in the transplant world. So that was smart. And then he the next battle to fight, frankly, was the resources of the hospital. For anesthesia, this is all-night work that is really hard, and no one loves doing that. And there's it was technically challenging for them. These patients were unstable, and it was not really easy to develop a cadre of anesthetists who were interested in this. After all, they all want to do the cardiac cases and not the liver cases. You need to know, by the way, that we now have 3 and sometimes 4 liver transplant anesthesia, liver anesthesia fellows now. It's really totally changed many years later. But it took us a while to develop a cadre of younger anesthetists who took an interest in this because, quite frankly, we get a different anesthetist each night. And when you're only doing a transplant every week or 2, it took a while for anesthetists to develop that expertise. It was a bit of a challenge in the time. It was also a personal challenge to enthuse them and try to, sort of maintain a positive spin on transplantation. We're speaking with the anesthetist that we want to get going at 3 a.m, please, because the liver will be here at 2 and we have to get on with things. And that wasn't really easy. And the next is the resources of the hospital, and because it's ICU dependent, it's to do that, eventually, I guess this was more Bernie as much as anyone else. We developed the multi-organ transplant program because we realized that as individual programs, heart, lung, liver, kidney, none of us are going to have the critical mass to be influential in the hospital. But if we bring it all together and put it under a single umbrella, then that has a cachet, and that works very well. And so the transplant program has really grown and blossomed nicely as a priority for the hospital. So those sort of logistical things were important. And frankly, it's tough to say. There's a lot of grunt work. For the first 5 years, we didn't have any coordinators. There was a phone call that there was a liver up in Ottawa. I would spend the next 45 minutes on the phone, calling in the anesthetists and the expert nurses and the blood bank tech and the coagulation tech, and calling in the patient and calling another patient to that patient they want to go, and the more program to make sure the airplane was going. And as we're driving down to do the donor, we're getting another phone call that there's another liver. It was a lot of personal time until we had individuals who would help us with the coordination of all of this. That was a lot of personal time. Oh, and there's one other thing. I think it was first 7 liver transplants. Gary Levy and I took turns sleeping in the bed across the way from that patient overnight for the first 3 or 4 days, just to make sure that they were okay. Wow. That intense post-operative care thing, they were committed to making. And so there was a staff surgeon or a staff hepatologist sleeping beside the patient for the first couple of days. Due credit needs to be given to Gary Levy, because a transplant program is very dependent on its hepatologist. That's where the patients come from. And Gary had done some training in transplantation in Pittsburgh with David Van Peel, and came back actually the Sunnybrook initially before he moved downtown. And Gary was really driven to develop a transplant program. So the combination of motivated surgeons and a particularly motivated hepatologist is quite successful in developing a program.
Dr. Greig, your name, and I should say your good name, certainly is synonymous with a lot of really amazing things. But one of them is clearly the world that surrounds education or surgical education. And as Amir sort of touched on, whether we're talking to your former residents, your current residents, nationally, internationally, fellows, whether I'm sitting in a room quietly listening to your sage advice at the HPBA committee meetings. Really, when I think of surgical education, honestly, I think of you, and unlike maybe a 1.5 transplant surgeon, I think you're a 1.0 surgical educator. So our questions really surround advice that you would have for residents in surgical training, for HPB fellows or fellows in general. How do you frame surgical education? What do you tell your trainees? I benefited personally from a lot of your advice from medical school forward, whether you remember it or not, it's another question. And then I guess finally, what do you think of the shift to competency by design? Does that have any implications, good or bad, from your point of view?
Yeah, so don't let me forget to do the last question, the CPD thing. I might forget if I just get rattling on.
You bet.
So the residency has changed without question. The residents are much more empowered over the past few decades than before, and that's probably a good thing. They're much more aware of their situation, a much less blind faith. If I'm supposed to do that, then that's what we do, because that's the way it's always been done, that traditionalist. And they are more challenging of more traditional methods, and that too is probably a good thing. There's clearly more camaraderie within the residency. I really didn't know the other 10 residents in my year. We never saw each other. We were busy being doctors. That clearly has changed, and residency education is much more formalized than it was. And I think what that does is it very basically guarantees that you're going to be able to pass the written and the oral exam. The challenge, I think, for residents these days is to get the adequate clinical training. They're very protected from themselves, from spending too many hours in the hospital, and they're protected from individuals who would ask too much of them. But And at the same time, the knowledge base is probably easier than it was before because the resources, it's all on your phone. You can look stuff up. CAT scans are done. If you got a good radiologist, they'll tell you what's going on, although my advice to the residents is you better be good at reading the x-rays, although we don't test you on that. It just makes you a better doctor. But the technical aspect on the surgical side, I think, is an ongoing challenge for our residents. And we certainly recognize that during the first year of the fellowship, there's a much steeper learning curve now than there was in the past. That our residents have not the open operative experience that we used to have 10, 20 years ago. Not their fault, it's just the way it is. And so my encourage, and they have to master both open and laparoscopic techniques, and probably have to learn how to do it on a robot as well. So that's a real challenge for them to get all of that. And that's just a time thing. You got to do one and another, like lots of them. And so, and I think our real challenge going forward is to get enough open surgery on. That's my bias, of course. I think there'll still be a role for open surgery. For trauma, transplant, the liver won't fit through the laparoscopic port. So there still is an important role for open surgery. And it may become a subspecialty someday. Who knows where that's going. But that's my challenge. And so my advice to the resident is jump on every opportunity to use your hands and be comfortable with handling tissues, because it's all about handling tissues and seeing planes. Anyone can cut it, but you have to know how hard you can pull, and when you see that's where I should go. There's translation to laparoscopic surgery as well, but just I've been doing some work with my brother on my car, and metal is a lot harder than tissue. And I said, he's got this expertise. He knows how hard he can bang that fender, and I don't, but I know how hard I can bang the liver, It's all about these subtle things that you learn. So that's my advice to residents. And of course, like the residency only prepares you for your fellowship. And my advice to fellowship to fellows is capitalize on every opportunity you can. And because you will end up operating the way your last mentor taught you. And during your fellowship, you need to have your antennae positioned so that you recognize the strengths and the weaknesses of each of your teachers. You're going to have some in the operating room who are really good and teach you well, and there's going to be others who challenge you more, and frankly, they'll be the ones that you'll probably learn more from if they don't help you as much as the others do. And you'll get something from everyone. Now, the current generation is very good at soliciting and seeking feedback, and it's important to get that. But you can't get that every time, and so you need to be introspective and take advantage of every opportunity. And like I said, recognize the strengths of each of the different teachers, because they'll all be different. At the Toronto General Hospital, we have 7 of us who teach liver transplants, and we have different styles. It's all similar stuff, but in each of them will impart different values and make different emphasis on different parts of the operation. And that's what the fellowship is all about, is synthesizing all that stuff. So that's my advice to fellows. With regards to CPD, this is just the educators, not the teachers, but the educators' next kick at the cat. I'll fully acknowledge that we don't do evaluation well. We certainly don't do it very objectively. Subjectively, we're all pretty good at finding the good surgeon, and the challenge, of course, is to help the struggling individual. I think we should come to recognize that not everyone can be a surgeon, and they start out being that way. Not everyone who gets in HPV fellowship is destined to be an HPV fellow. I think we need to acknowledge that, although that's a real challenge too. There's a couple of my challenges during my career. But CPD is the administrators attempt to improve on our ability to evaluate. It adds more structure to the evaluations. We went through structured evaluation tests, OSATs, and the Ottawa score, and all these things, and they've been adopted to different extents by different programs. And CPD I see as being similar to that with these milestone things. It's trying to get the surgeons to more objectively evaluate and give feedback to the trainees. Part of the problem is you get what you pay for. And none of the surgeons are really paid to do this. And they're busy individuals. And so it's we'll see if it makes much of a difference. It's instead of CanMed's competencies, which was the tool of the decade, the previous decade, now it's CPD. We'll see where it takes us. Part of the problem with CPD is it tries to compartmentalize many of the things we do, and life isn't like that. You're starting off thinking this is appendicitis, and you end up to your eyeballs taking out the sigmoid colon because things are not that tidy in life, and so there's going to be some limitations to it. But it just acknowledges that we're still struggling with our abilities to effectively give feedback and help the struggling student. Those are my thoughts.
Those are some really sage and really deeply wise comments on some real challenges for our generation, a lot to think about. I think we'd be remiss to not ask you, like we were talking about before we started recording, about some of your passions outside of medicine. I've heard that you're not only just a phenomenal musician, but also a dedicated gamer. Can you tell us a little bit about those outside interests that you've developed outside of medicine, and how did you do that as a person who was sleeping beside the patient 50% of the time?
So I became addicted to World of Warcraft through my sons, because they were serious gamers. In fact, one of my sons took a year off to play World of Warcraft, and it was either fight them or join them, and I did the latter, so that when I came home, Kevin would say to me, "Hey, Dad, I got your guy some new armor. I just sent it to you." So it's a way to relate to my children. On the other hand, it's a decompressor. It takes your mind off the rest of the world. And in the high stress environment that any surgeon works in, we do need to decompress. Whether it's at an hour at a time with World of Warcraft, or because you're off this weekend, and you've got your bicycle club on Sunday mornings, and you go biking for 26 kilometers or whatever they do. It's very important to keep that sanity. It's difficult to maintain a serious hobby through the formative years of 35 to 55, because you're so busy becoming an expert at who you are that most of us jettison our personal hobbies and struggle to maintain our family commitments. But my advice to my colleagues is that don't lose them entirely, because they're very valuable to resurrect in the next couple of decades when you've got a little more time and you are who you are, and they'll come in very handy, because when it's time to hang up the OR cap, you need something else to do every day. And that, for me, as you know, that's music. It's really neat, because I thought I was an okay guitarist, but I'm starting to take lessons again, and I feel there's huge challenges, and I'm learning something every day, and I'm getting better at this, and so you need something that does challenge you. That would be my advice. And so if you can maintain some of that then that will be valuable to return to when it comes to retirement times. Just parenthetically, I'm not playing quite so much World of Warcraft, and the new version is going to come out in a couple of months' time. I'll probably sign up for it and pick my warrior up to 120, but that it seems to have lost its luster, perhaps because my sons have stopped.
That's fantastic. Dr. Greig, the last question we want to ask you, and maybe it's the most important question, I don't know, but and you might agree or disagree with my subsequent statement here, but I think as surgeons we see lots of examples of retiring poorly, and by that I don't mean that in a judgmental way, but just in terms of challenges, personal challenges, moving on to the next chapter in the post-surgical life. And it appears from the outside anyway, and in talking to you a lot about it, that you've done that with elegance and grace and deep thought, as usual. So I was curious how you viewed that and how you did that, and what you would tell any of us that are, 10 or 20 or maybe even 30 years out from that time point. But what advice would you have, and how do you think about that?
I'm going to start before retirement. I'm going to start around 60. And I think it's very important that an individual be sufficiently self-aware, because we change. I have a naive enthusiasm for life and excitement, and I go too fast and all that business. That was my nature. And we change with time. We become more cautious. We worry more. Yeah, we can hide the tremor. The tremor I can control in the operating room. But we don't look forward to having to resect the portal vein the way we used to. Let's get portal vein case. I didn't really want to. Okay, I'll tell you about the portal vein today. Life changes, and you have to be aware of that. And we become more cautious. And because we take our complications much more seriously, we should have done that differently. I think that's human nature. And I saw a number of senior surgeons who had lost it, and I was embarrassed for them. And I was very aware of that in myself. I could see that in myself, that I was much more cautious. And before I made a decision, I'm unresectable, I better make sure I'm not missing out on this, because I don't want to deny someone an opportunity, And in the operating room, the same sort of thing, and I would call my colleagues. But we do change, and I think you have to be aware of that. And some of us change sooner than others. And you need to have that self-awareness and know when it's time. Number two, obviously you have to have the financial resources in place. And when I checked with my financial advisor, and when I sat down with her, it's pretty clear to me that I had more money than time, that any more was just greed or more for the kids when I die, and it's time to move on. And so you work towards that. And so you develop a goal, because I developed a goal and all that, and you have to have the succession stuff in line and all that, people will replace what you're doing and all that. But then in planning, I remember, I have a number of friends who are my age and who retired. I used to say to them, "Well, what do you do all day?" They actually do. Paul, you'd be surprised how busy you get when you're retired. Yeah. What do you do all day? They give me these messy answers. And you read a little bit here and there, and you talk with people and stuff, and advice is free. But I sort of like this advice I got that suggested you should have at least three things that you're working on, and one of them should be physical, because we sort of start to lose it. And so I've got three things, that have enough of a challenge that when you get up in the morning, there's something you got to do. That's what you want to do when you're less at the beck and call, and you're not going to get called at 3 o'clock in the morning, and I'm not chronically exhausted. It's quite extraordinary how exhausted one really was, and you didn't realize it, But the advice I got to have three things that you're separate from the house obligations, because the house can eat you a lot. There's always stuff to do in the house. There's always work to do in the house. But no, you have to have things to do, And so, as you've learned, music is my number one thing. I've got 2 bands and work with another guy taking lessons. I'm recording, and that's coming along pretty well. We're starting to gig. I'm training to do some more mountain hiking because I love being high in the mountains, and look forward to doing more in the Canadian Rockies once I get this other thing under my belt. And I got a project with my brother, which I'm thoroughly enjoying, and at the end of it all, I'll have a summer car. And I was just chatting with him today about what we'll do next, So that would be my advice. Be introspective, know when it's time, and put a good couple of years planning to it, because it's pretty easy to wake up in the morning and have another drink because it tasted pretty good.
Thank you so much for this. Thank you.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.